Well, good morning to everybody. We are very fortunate this morning to have Dave Skanga and Steve Erkenbrock from Hoskin, Farina, and Kampf join us this morning. This is John Hildebrand. I'm the President of Business Development at Auto Paychecks, and I am blessed to be joined by Manon Jacob, who is all things marketing and communications on our side. So thank you all for joining us today. We really appreciate it. For those of you who might not know, Auto Paychecks provides payroll and human capital management services nationwide, and we are very fortunate to be joined by a large section of our community and partners in the area. We have been committed for quite some time into bringing reliable information to our clients and partners in monthly webinars. This is actually our 13th webinar. And today, as I mentioned, we have Dave Skanga and Steve Erkenbrock here, who are attorneys at Hoskin, Farina, and Kampf. Dave and Steve are going to present today on a healthcare primer for employers. We are very grateful for them to spend that time with us today and to share their expertise. As all of you, I'm sure, are aware, healthcare is one of the most uncontrollable components of overhead that businesses face today. The only predictable aspect of it seems to be that every year the costs rise, and sometimes they're in double digits. This challenge impacts everything from strategic business planning to employee retention. And the purpose of today is to give you an overview of the current environment so that we can make better informed decisions that serve our company and employers here. So a little bit of a bio for Dave and Steve here. Dave Skanga is the managing shareholder at Hoskin, Farina, and Kampf here in Grand Junction. He has been there for over 35 years. Dave has developed an extensive expertise in the different components of healthcare, representing large employers, small employers, hospitals, physicians, insurance carriers, brokers, and health information exchanges, and other key healthcare, those that are key to healthcare delivery in our system. Steve Erkenbrock is currently counsel at Hoskin, Farina, and Kampf. He has a diverse career. I find this really fascinating here. He was CEO of Rocky Mountain Health Plans, providing coverage in all lines of business, including commercial Medicare, Medicaid, and CHP+. He was a trial attorney for 20 years, including litigation concerning government healthcare programs at both state and federal levels. In the 90s, Steve served as the Colorado's Chief Deputy Attorney General, supervising approximately 200 lawyers representing state agencies, including healthcare issues. Before that, Steve was in private practice and served as Mesa County's elected district attorney. And over the past 15 years, Steve has been repeatedly appointed by the Colorado legislature to serve on healthcare boards and commissions. Dave and Steve's information will be provided at the end of this webinar, and we encourage you to enlist their services for additional help should you need it. A little housekeeping before we get started. We ask you to stay on mute to avoid interruptions and feedback during the presentation. Please submit questions as we go through the chat feature, and we have about between 15 and 20 minutes scheduled at the end of this to answer as many questions as we can, and we will try to group them together. We tend to get questions in clusters. And this presentation will be recorded and distributed to all attendees later. And I'm going to get out of the way here. Dave and Steve, thank you so much for your time and willingness to present to our community.
Thank you. I get to go first. I'm not sure why, but you guys lose. But I wanted to emphasize, excuse me, one of the points in the introduction, that this is really, it's a very broad kind of picture of the landscape that we're trying to present here so that you can take a look at your specific healthcare issues as you deal with trying to provide coverage for your employees and yourselves, and put that in the context. When I was CEO at Rocky, one of the most frequent questions I got is, why are healthcare costs so out of whack with the way the rest of the world is running? And that's what we're going to try to give here. There is a volume of information, so bear with us. We did want to create a period of time at the end for Q&A. And so with that, I want to start on kind of a positive note, if you will, or at least including a positive note. And if you're wondering how in the world can I find anything positive to say about healthcare, well, consider what I like to call the good, the bad, and the ugly of healthcare. So the good is perhaps best represented when we think of babies, because everybody loves babies. So for those of you who are kind of in my era, the baby boomers, if you think back, the last time a baby was born in the White House was when John Kennedy was president. The baby was not John Kennedy, which is what almost everybody thinks. The baby was Patrick Bouvier Kennedy. He's born in August 1963, 2 weeks before Martin Luther King delivered his I Have a Dream speech. Patrick was due to be born 1 week after the speech. He was born 3 weeks premature. He was born into the most powerful family in the country. He was born in one of the richest families in the country, and he was born in a state-of-the-art medical facility in Boston, Massachusetts. And like almost every baby born 3 weeks early in 1963, Patrick died within days. Fast forward a generation to 1984. Daniel Stephen Birkenbrack was born, not in a state-of-the-art medical facility in Boston, but in a hospital in Grand Junction, Colorado. Not to a powerful family, but to a guy, if those of you who were in Western Colorado in the 80s might remember, who was trying to figure out how to make a living practicing law in a small two-person law firm. Daniel Stephen Birkenbrack was not born 3 weeks early, he was born 5 weeks early. And like most babies born in 1984, 5 weeks early, Daniel did fine. Today, Daniel has lived in Korea for 3 years, in Germany for a year and a half, in France for a year, in Brazil for half a year. He speaks all of those languages. He has an MBA with an emphasis in finance, and he runs the regional audit team for FEMA in this part of the country. He seems to have recovered his premature birth. And today, we save babies routinely, born not 3 or 5 weeks early, but 5 months early. Babies who weigh less than a can of Diet Pop. This improvement in quality over 2 generations is not restricted to the NICU, to the neonatal intensive care nursery. Everyone on this call knows a cancer survivor. That used to be a death sentence. Everyone on this call is aware of the fact that we transplant hearts, we transplant livers, kidneys. We can reattach limbs. We can reattach almost anything. For those of you who might remember Lorena Bobbitt and John Bobbitt, that we develop pharmaceuticals routinely. We had a century event with the pandemic, and we came up with not 1, but 3 vaccinations within a year. That's not unusual. Some of you of my age may remember Jerry Lewis telethons about muscular dystrophy for these tragic kids that couldn't walk. My last month at Rocky, and I've been gone for a year and a half from my time as CEO of Rocky, my last month, we dealt with a baby who actually got a drug that cured muscular dystrophy. This quality, and if you don't think that's important, that's because you're not accessing the healthcare system. Let me assure you how important that is to that kid's mom. That's the good part of healthcare. Here's the bad part. It costs a lot of money. How much money? $3.8 trillion a year. That has doubled, by the way, in the last 20 years. And when you use a number like 3.8 trillion, it's kind of hard to get your mind around it. So let me put it in these terms. $3.8 trillion a year is $43 million an hour, every day, every week of the year. It is a volume of money that's flowing into healthcare. And the ugly part of healthcare is, how do we address that? Because every one of those $3.8 trillion is going into somebody's pocket. I like to look at the healthcare world as there are people who take money out, hospitals, doctors, insurance companies, pharmaceutical companies, and there are people who pay money in. That's you. In fact, every dollar in that 3.8 trillion comes from one of 2 pockets, the business community or consumers. You say, well, what about government? Where does government get its money? From taxpayers. Those 2 pockets are funding that, and that's a lot of pockets that it comes out of, going into a relatively few number of pockets, hence the challenge. But the other challenge is we don't really have a healthcare system. When people say, why can't we have a national health service like England, or why can't we have a system like Switzerland or Germany or Holland that uses insurance companies with government oversight? The answer is because we don't have one system to address. We have myriad silos in which we deliver care. And that's what we're going to talk about now. Just look and listen to the number of silos we have. We'll break them down broadly into commercial silos that Dave will talk about, and then government silos, which I'll be back to talk about. Dave?
Okay, let me get to, we have a slide here on these silos. I'm going to talk about commercial silos. We talk about silos. We're talking about where premiums are set within a group, where laws govern a group, and generally healthcare is provided within a group. Now, if I talk about commercial silos, I'm going to start with the large employers. Large employers are employers that are greater than 100. And how do we calculate how many employees someone has? You look at full-time employees and you look at FTEs to make the calculation. So you have greater than 100 employees, you are a large employer. Now, what do large employers, how are they obtaining coverage? Generally, they're self-funded. That'd be a majority. Some are fully insured. Next silo I'm going to deal with is small employers. And we'll talk later how the rates, premium rates are set for these different silos, because I think that's helps, gives you some information on maybe what you can do or some strategies you may be able to undertake to help you with your costs. Small employer, that's one silo of small employer. Unlike large employers where you have self-funded, which is really separate from fully insured, in small employers, you're in one group. I broke this into two different types of small employers. Larger small employers, which the government came up with that term. I really like it. I'll leave them to come up with a term like larger small employers, but larger small employers are between 50 and 100. And less than 50 small employers. The reason I broke those into two groups is because the larger small employers are subject to a shared responsibility payment if they do not provide coverage. They have to provide coverage required by the Affordable Care Act too. And that impacts what that employer would want to do. So we'll talk about that later. The third silo, which has grown over time, is the individual coverage silo. And when I talk about individual coverage, I'm talking about generally the way people can get individual coverage either on the exchange or off of the exchange. So if you go to the health insurance exchange, you can obtain coverage. If you want a subsidy, you have to go into the exchange. Otherwise, you can't get a subsidy. And the individual cannot get a subsidy otherwise. But they also can buy plans from the carrier without going into the exchange. That would have to be non-subsidized. In the exchange, you can get both subsidized or non-subsidized, depending on what your income is. So those are kind of the commercial silos, the way I would break them down. There's subsets maybe within there, but that's the big grouping of them. And later we'll talk about how the premium rates are set and how that could impact you as a person, a consumer of healthcare coverage.
So in addition to those commercial silos, we have the government silos, which actually have been increasing over the last 20 years, if you've noticed. Used to be way back when Patrick Kennedy was born, we didn't have a lot of these. That was before Medicare, before Medicaid. Those things came in the mid 1960s, and they're so well established now, we tend to take them for granted. So let me start with those coverage silos of the government. You have Medicare, which is care for the, I don't like to consider it elderly anymore because I'm in Medicare now. But they're care for people who are over 65 years old. But within Medicare, you have sub-silos. You have straight Medicare, which is basically the government says, here's a card. Congratulations, you made it to 65. Here's a card. Good luck finding a doctor. You have Medicare Advantage plans where the government uses private insurers that build a network and coordinate care. You have Medigap coverage, which is a commercial-like product to cover things that straight Medicare does not cover. And over the years, you have had all sorts of other options, Medicare Plus Choice, Medicare cost reimbursement contracts, as separate silos created within the Medicare space. Each one of those is administered in a different way and has a different process for calculating what the payments are going to be, both what you pay into it and what the government's going to pay the physician, what the physician or the hospital takes out of it. Set aside Medicare for a second, now that you have that, those number of silos, and you have Medicaid. Medicaid is a program that's administered at a state level. It is theoretically optional, but every state takes it up. Initially, there were a few states that didn't, but what they found is that when you look at the categories of eligibility, because Medicaid serves more than one type of person, there's a Medicaid category of eligibility for kids whose parents or parent is on aid to dependent children. There is a Medicaid category for old age pensioners, for the disabled population. There are at least 7 categories of Medicaid, and it gets more complicated than that because the program is jointly funded by the federal government and the state. And so the state has some flexibility to create different Medicaid products within the oversight of the federal government. And then the federal government decides how much of the Medicaid budget it's going to pick up in a given state. So you have 50 states, you have 50 different types of Medicaid, and within a state like Colorado, you also have different ways that Medicaid is administered. I think you're probably getting a sense of the complexity of the number of silos that we have. I'll just mention in passing other government silos like the Veterans Administration. Been in the military, you're a veteran, you can get your care through the VA. If you are a career and you retire, like my dad did, then you get TRICARE for life. You have the Federal Employee Health Benefit Program, which is, as it says, a program for the federal employees, but it's sort of a commercial kind of product with this twist. Rocky used to do the federal employee program, and you have to give the federal government the best deal of the large employers. They can come back and audit you for years down the road and say, we just discovered that you're giving Safeway or Kroger or United Airlines or any large employer a better deal. You owe us more money. And so these silos, all of which stand alone, but they all impact each other. Because understand, and you deal with this yourself, when you look at controlling your healthcare costs, you might be a small employer. So you're looking at the small employer silo. And there are 2 ways to control your costs. One is find ways to spend less money because you actually create better contracts or whatever. And the other is, hey, shift the cost to somebody else. And this happens quite a bit. So let's talk about that cost shift, if you will, with how the government silos impact then the commercial silos. So take a look at how the government reimburses providers and how the commercial world reimburses providers, because that becomes a very critical consideration. The government says, okay, we have Medicare. This is what we're going to pay for Medicare, period. Take it or leave it. There is no negotiation. The Medicaid does the same thing. Now, the number is not quite that arbitrary because Medicare rates are set with an advisory panel that has hospitals and physicians, both specialists and primary care, mostly specialists, that say this is a fair rate of reimbursement for the Medicare program. Medicaid will typically be a percentage less than that. So that's a very different way of getting providers, of getting doctors and hospitals to serve this product line than the way it works in the commercial world. In the commercial world, if you want to be an insurance company and you want to offer a product in a community, you do that under the auspices and regulation and supervision of the Division of Insurance, or the Department of Insurance in some states. And in order to do that, before you can do that, you have to show the Division of Insurance that you have a network of physicians that will serve the members who buy your product as an insurance company, which means you have to enter contracts with each and every physician. Rocky Mountain Health Plans, back when I was there some years ago, was not the biggest health insurance company. And by the way, Rocky has since transitioned. It's now part of United. All of my talk about Rocky is going to be back in the days when I was CEO, when we were independent and community-based, because I think it helps illustrate this. So small Rocky Mountain Health Plans based in Western Colorado, in Grand Junction, Colorado. We had 10,000 doctors in our network, 10,000. We had to enter contracts with each and every one of them. We had to make sure that each and every one of them, if they were administering the federal programs or the state programs, were doing it the right way. It's a lot different than the way that the federal government or the state government contracts with providers with that take it or leave it approach. So if Rocky wanted to serve Gunnison, Colorado, it had to make sure it had an adequate network there, or they wouldn't be allowed to sell products in Gunnison, Colorado. Well, how does that impact you then? Well, if a physician is sitting there and can negotiate with one payer, but can't negotiate with the other, what happens is the physician will say, or the hospital will say, this is the amount of money that I want to make. And so if Medicare and Medicaid is underpaying me, the commercial world needs to pay me more. And when the commercial world pays more, you pay more for your insurance product. So there is a chart in front of you now. This chart is actually fairly old because back in about 2007, I was appointed to the Healthcare Reform Commission in Colorado. There were 24 people from all over the state, all different backgrounds. Of those 24 people, 23 of them came from the Front Range or the eastern side of the Continental Divide. There was one from Western Colorado. There was one insurance company, and that was me. But one of the things we looked at was this cost shift, because every time we negotiated with a doctor or a hospital, they said, well, we need to charge this because we're losing money on Medicare, we're losing money on Medicaid, and we're certainly losing money on the people who don't have any insurance at all, who have to show up at the emergency room, and we have to take care of them. So we commissioned Lewin Associates, an actuarial firm nationally, and said, tell us how much more commercial payers are paying because of the underpayments of the Medicare, Medicaid, and the uninsured. And that's the chart you see in front of us. And the bottom line, and for years I said, so take a look at this, you're paying 30% more as a commercial payer or a commercial employer or consumer because of the cost shift that's going on. And the state of Colorado said, we ought to address this. And they did a dozen years ago. Governor Ritter, when he was in his last year, put in place a hospital provider fee to generate dollars to address the cost shift. And it worked in this sense. The hospitals got basically $400 million a year, but it didn't work in another sense. That number, that 30% higher number, didn't come down, not a single time. At no time did a hospital say, hey, this is great. We have money coming in now, more money coming in to deal with Medicaid and to deal with the government lines. At the same time, the Affordable Care Act came in that covered people. And so all of those boxes, the gold, the blue, the red, they went up closer to that baseline, but the red line, the green box did not come down. Why would it? It's a private sector. If they can get 30% more, why wouldn't they? And that's the reality of what we saw. So that cost shift will drive prices up, but if you address it, it won't necessarily bring them back down, not without another step. That's the issue that we are one of the many issues that we are wrestling with here. So we're not going to shift to how it actually gets from this theoretical sense and the macro sense to the micro sense of how your premiums get set. Dave, anything you want to add before I shift to there?
No, I think we have to move to that.
Okay. So one of the things that when I was CEO at Rocky, I repeatedly said is, you need to understand that unlike most businesses, an insurance company does not get to price its product wherever it wants. Insurance companies in this whole discussion are not terribly popular. There's a reason for that, by the way. The reason that insurance companies are not popular when you think about it is they communicate with people in one of three ways. they send absolutely unintelligible explanations of benefits that we put at the top. This is not a bill, which pretty much guarantees it'll be thrown in the recycle bin right there. The second thing is we increase people's premiums. If, annual enrollment comes around and you brace yourself, where will it be 10%, 15%, 20% more? And the third way is we deny claims, because like at Rocky, we would pay 99.8% of the claims electronically. Consumer would never know. But if you bought not to disparage anything here, if you bought a Kia and you put in for a BMW service and we said, yeah, that's not the product that you bought, and we denied it, that does not serve well. So hard to believe that insurance companies don't have a lot of credibility here, but circling back, the rates are not set by whatever profit I want to make. Other than this, the rates get set in this way. And I'll do this pretty quick. We can go into more detail in the Q&A. If you're setting rates for next year to say, here's the product we're going to offer and the price we're going to offer, you take a look at the last year and the population that you're talking about. So a large employer, and Dave will go into more detail on this, is going to look at a different population than a small employer will. But whatever that population is, an actuary comes in, looks at what the actual cost of coverage was for that population in year one, completed year, it's doing the calculation in year two for rates in year three, and says, here's the amount of money you're going to need to generate through premiums in order to pay claims. Because of course, the worst case scenario here is you don't have the money to pay claims. It's bad enough to have to pay the amount you have to pay for health insurance. You don't want a company that said, appreciate all those premiums, yeah, we don't have enough to cover the hospital bill. That won't happen. And the insurance commissioner is going to make sure it won't happen. So the actuary builds those rates. There is an amount of margin or profit in there for the company that gets reviewed also. And every single rate has to be approved by the insurance commissioner, who is looking at this from the perspective of the consumer. Is this a fair rate? Won't let you put an exorbitant profit in there, won't let you pad anything, has total insight into everything. In addition to that, the Affordable Care Act, when it was enacted a little more than 10 years ago, said there is another thing we're going to address here for insurance companies. We're going to limit the amount of profit they might even be able to make, so that depending on your group and the silo that you have, either 80 or 85% of the premium dollars that come in have to go for care. They have to go out to a hospital, to a doctor, to a pharmaceutical company, to a pharmacy, to durable medical equipment. They have to go out to care. That includes, Rocky had its own home health nurses. Couldn't count them. You can't play games. If you had to go to a third-party provider in order to make that. And if it didn't, if you actually guessed wrong and you had paid less than the 85% to providers, well, you had a significant sanction. You had to rebate the dollars, which is not just a matter of the money involved, it's a matter of the chaos involved of having to find the people who actually paid the premiums and get it back. Every carrier would try to avoid that as much as they could. At the end of the day, then, the insurance commissioner looks at every rate and says, I'm going to approve this or I'm going to disapprove it based on the interest of the consumers. And within that, then, there are differences for how large employers, small employers, and the individual market is rated. Dave will address that.
I'm going to deal with this kind of more of a micro view of it, a little bit more micro, because I think it's important for employers to understand how premium rates are set for the silo they are in, because that will help them determine what strategies they should have. I'm going to start with the large employers. Large employers in Colorado are experience rated. That means that the insurance company will look at what the prior experience was of the employer. How sick were they? What were how many claims did they have? And based off of that, they will set a premium rate. So a large employer can impact the premium rate by having if their employees are well. If they have employees who are usually younger, do not have many medical conditions, it will impact their premiums. They can get a lower premium rate. That unfortunately does not apply with small employers, fortunately or unfortunately, depending what bucket you're in. With small employers, they are community rated. It's a modified community rating. But what they do is they take all small employers in a pool and they'll set a premium rate. That will only be modified based upon age, location of the employer. In Colorado, if you're in a metropolitan statistical area or you're in a certain rural counties, they group together. That'll impact what your community rating is. Also be impacted by tobacco use or whether you have an individual or family plan. Those are the only factors they look at. So when you say to yourself, well, I have a really healthy population of employees, that's really not going to impact your premiums as a small employer. Age will. There'll be an impact on age because age is one factor, but because of limitations in Colorado and under the Affordable Care Act, the differential in age is not as great as it actuarially would justify. There's a limitation on what you can have as far as age differentials, but there are age differentials which will impact the rate that a small employer pays. And when I said there was larger small employers and then the under 50 small employers, well, in Colorado, because Colorado expanded the definition of small employer to include those less than 100, they all have the community rating. So no matter if you're 61 employees or you're 20 employees, you are community rated. Individual rating is also a community-based rating. They do not, a health plan cannot determine someone's medical condition and set the premium based on the medical condition of that individual. That's a community rating also. Again, the factors I talked about with small employers would impact the rate for an individual. But if an individual has cancer and is obtaining coverage in the exchange, that person, if they were the same age as another person who's perfectly healthy, they would pay the same rate if they lived in the same locale, because it's not impacted by the individual health status of the person. This is important for you to know as an employer, because that can say, what can I do to impact what I'm paying? And if you understand how these premium rates are set, it'll help you do that. I talked a little bit about self-funding, and Steve's comments are really based on setting insurance premiums. There's also something to keep in mind. Over 60% of all coverage in the United States provided by employers is provided by self-funded. And by self-funded, it's partially self-funded, really what it is. And that means that the employer pays a portion of the medical costs up to a certain level, depending on the claims. Then a stop-loss carrier will pay amounts over that. The stop-loss carrier sets a premium for the employer, and that premium is set based on the health status of the individuals, and they're allowed to do that. There's no requirement under any law, federal law, state law, that says a stop-loss carrier cannot look at individual health status to set premium rates. And that's what happens. So in Colorado and in most states throughout the country, because it's governed by federal law, stop-loss premiums can be set based on the experience of the individual, the health status of the individual. We talk about, well, why are premium rates rising? Why is it faster than inflation as this is going up? And Steve will address that. We've told you how the premium rates are set. Now Steve can say, well, some of the thoughts on why, in fact, we see premium rates are increasing more than inflation increases or other costs of goods.
And I'm going to just spend a couple of minutes on this in order to make sure we have time for Dave to address the next category, which is specific employer strategies. But the point I want to make on this, because it is a very frustrating thing for people to say, look, we don't really have much of an inflation issue in our commercial world these days in this economy. We're 1, maybe 2%. So how is it that rates are going up 10 or 20%? And the answer is because what drives rates is totally unrelated to the consumer price index. Some of these things are good, believe it or not. Some of these things are bad, and some of these things are mixed. And let me just talk about a couple of the good things, a couple of the bad things, and a couple of the mixed things. So a couple of the good things, the technological advances we just said. It cost money to develop a vaccine for the pandemic, but 500,000 people have died in the last year. 500,000 Americans have died. So it's good to have those vaccines. We have developed so many things, robotic surgeries, way to do hip replacements and knee replacements that create less pain and less immobility for people in terms of the recovery time. These are good things that have happened. Frankly, aging is a factor. My grandparents died average age of 70. My parents and my in-laws died average age of 80 plus. Those are not low cost years. And if you say, yeah, but they're on Medicare, remember that cost shift that you have that comes over and impacts insurance premiums. So some good things, contrary, you may remember Governor Lamb so many years ago, who said that old people might want to consider having a duty to die and lower healthcare costs. We haven't quite gone down that road, and I don't know that very many people who think that we should. But let's talk about a couple of the not so good things that drive cost. One is the defensive practice of medicine. You can argue about the allocation of those $3.8 trillion and whether they ought to go to hospitals, doctors, insurance companies, pharmaceutical companies, or be retained by the consumer. But nobody that I've ever heard in healthcare has ever said, lawyers ought to get some of those dollars. No disrespect intended, Dave. But that is exactly what happens because we have a medical malpractice system that drives unnecessary medical procedures. If you're an oncologist treating a cancer patient, you are not just doing the things that you think you should prudently do to help this patient deal with his cancer. You are prescribing everything that a tort lawyer might come in and look at your file and say, why didn't you do that? Who pays for all of those unnecessary proceedings? All of us. How many are there? American Medical Association says about 20% of the procedures that are done are not medically necessary. Let's also look at the mixed world. I mentioned when we were talking about quality, the little girl with muscular dystrophy in my last month as CEO. She took a drug. She's running around today. She's got pretty happy parents. The drug costs $2 million, one dose. Who doesn't want a little girl to recover if we can do it? But finding a way to look at those costs is critical. And so you can't just say they're all bad. You can't say we just got to live with it. We have to say is let's roll our sleeves up and figure out how we can help deal with cost in a particular silo. And that takes us to Dave.
So the question is, you heard all this about how healthcare is delivered throughout the United States, all the issues. The question really boils down to, for employers, is what are some strategies you may be able to employ that could help with reducing some of your health coverage costs? And I have employers ask me this quite often, what can I do? And kind of depends on what bucket you fall in. I talked earlier about these silos, and when I talked about large employers, I said it was greater than 100. Well, under the Affordable Care Act, large employers are 50 or greater. And that's important because if you have more than 50 employees, you are subject to employer shared responsibility requirements, meaning you have to provide coverage. So that impacts what your strategy is. I'm going to just touch on large employers quickly and focus a little bit more on small employers. For large employers, I talked earlier about experience impacts what their rates can be. Large employers, majority, are going to be self-funded, and experience impacts them in that manner because their stop loss premiums can go down if they have better experience. In the insured market, experience also helps with that. They have better experience because it impacts their insured premiums. So what do? Large employers can have wellness programs that can help with that. Large employers, as small employers can have larger deductibles, increase employee contributions. But large employers have a little benefit here. They do not have to offer a metal plan. They could offer a non-metal plan, one that is still coverage that is minimum essential coverage, what they call under the Affordable Care Act, but in fact, it does not meet a metal. A bronze level type of plan, a minimum amount of coverage that you'd be required otherwise to have under an insured product. They can do that because they can design their own product, and they can do that under self-funding. So that's things that they can do. They're also direct primary care they can make available to employees, which can help maybe with some preventative care, and they can do HRAs and HSAs. Small employers, a little bit more difficult. What can a small employer do? As I said, they're not experience rated. They're in a pool. So how do they impact their premiums? How do they impact their costs? Well, if I'm a smaller employer, I'm under 50, I'm not required by law to provide coverage. So I could say, I'm not going to provide coverage. I'm going to just increase my salaries when I'm going to pay my employees, and they can go get their own coverage. The benefit of that is if you are a employer who has individuals who are not making a lot of money, they may be able to get a subsidized premium in the exchange. So they can go to the exchange and get a premium that's going to be subsidized. And by you not providing coverage, they have a right to go get that. They may have a right to go get that. The problem is they're using post-tax dollars because individual premiums are not deductible. What else can they do? One of the things they can do that's new, there was a law passed regulation passed actually in 2019. It came into effective 2020, and it's now starting to get some legs. This is individual coverage integrated HRAs called ICARAs. The good thing about these are allowing a small employer to use pre-tax dollars in a health reimbursement arrangement that would allow individuals to use the pre-tax dollars to go to the exchange and get a plan. Now, they're not going to be entitled to a subsidy with that plan if it's affordable what is being provided to them. But that's pre-tax dollars can be used in an exchange for an individual plan. So I think those could have real legs. And in Colorado, it becomes very important because in Colorado, we have this reinsurance program, which is talked earlier, has dropped the individual rate. Individual rates and small employer rates in the past were fairly equivalent. Maybe individual rates may be a little bit higher. Now in Colorado, they are lower. They've dropped by about 17% is the estimate on individual plan premiums. So ICARA could have some legs that could help a small employer provide coverage to employees. The problem with ICARA is you have to, how are they administered? Having a good third-party administrator do this could help out because employees have to go to the exchange to pick out a plan. The employer doesn't have the plans for them. So it may work better with smaller employers, although there is no size limit on having it. A large employer could offer an ICARA. So and you can avoid employer shared responsibility requirements if the coverage provided is affordable. If you are a larger small employer, between 50 and 100, you have these employer shared responsibility requirements. And right now, if you didn't provide coverage to your employees, 95% of them have the right to obtain coverage, your full-time employees, you would have a penalty of $2,700 for every employee you have per year. That's a lot of money you'd be paying. So larger, small employers, you have a shared responsibility requirement. You're saying, I have to provide coverage. How do I do that? There is some strategies out there of what they can maybe do. Some employers that are, let's say, 60, 70 employees say, well, I may get assessed with a penalty, but I get a 30 employee reduction. If I have 30 full-time employees, I can always deduct 30. So I only have 30 full-time employees. All my other employees are part-time employees. I do not have them work over 30 hours. And that's a strategy that some use. I only use 30 full-time employees is all I have. And that way I get that credit off of my shared responsibility payment so I don't have to pay a penalty. And that's something that some employers do. We want to talk a little bit about, I know we're running out of time here, but we maybe get some broader picture things and maybe what's in the pipeline, Steve.
So, well, let's do this because we are in the time we had hoped for Q&A. We can talk about either things that have been done in the past from systems or communities or states that have helped control costs, not on the micro level that Dave just talked about, but more of a macro level. We could also talk about concepts like Medicare for all or public option, which seems to be in the news. But why don't we see what questions there are? And if you don't ask a question, then I'm going to start talking about some of those things. So that ought to create some questions.
Okay. Yeah. So gentlemen, I've got a question for you. So I understand that Summit County now has a community health, as a group, a community healthcare policy that's offered to the community. And it was my understanding that that might be developed in Mesa County as well. Do you have any news on that or updates on that?
Yes. So I'll take the first shot at it, and then Dave can. So Summit County a few years ago sort of came together as a community and said, why don't we all get around the table and let's do it so we're not getting in any kind of antitrust problems here. And so involve the government. This was done under the auspices of the Division of Insurance. They were present and watching every step of the way to say, how can we band together large employers, small employers in the community and directly negotiate with the hospital? Because the challenge there was that they were paying fees for the hospital. There was only one hospital in the community, so they didn't have any choice about this. And when you have that phenomenon of a provider that has dominant market power, then that provider can negotiate rates that are different. And so as a matter of fact, that facility in Summit County, for example, in its emergency room, was charging 850% of Medicare, 8.5 times Medicare. And it was part of a system that down in Denver was charging Medicare or slightly over Medicare. So the community came together and said, how can we sort of level this playing field and bring more lives? It's very complicated to do, but it can be done. It's a great example of a community approaching it. I know that communities have looked at that. Mesa County has looked at it. Durango has looked at it, but it requires the community to sort of band together in a Three Musketeers, one for all and all for one, because what won't work is to give each individual employer the ability to say, well, I'll see where I get a better deal, because then the providers can start peeling people off. Dave?
Well, one of the dynamics that Summit County have to realize also was that a lot of money they make there from individuals who are outside the area that have healthcare coverage, and they get injured skiing, they get injured in other outdoor activities. And that's where such a hospital system can make a fair amount of money, but they don't want to charge the local residents that amount. So they have this dynamic there where you have these individuals who come into Summit County, use the healthcare service there, pay a fair amount because they're using usually insured plans, and they don't want to charge those same rates to the individuals. And the hospital was involved trying to help the community to come up with this, because that's the dynamic they have in that community.
Yeah, that's what I just did here.
Other questions?
Need to recall. Let me read it off to you.
Yeah.
253-215-8782.
Did we lose you?
Manon, we can't. Do you have any questions? Because if not, I can continue to elaborate on the community approaches.
She must have lost me.
Welcome to Zoom. Enter your meeting ID followed by pound.
4857.
Oops, I did that wrong.
You entered 940458. This meeting ID does not exist.
940. 4857. 8567.
You entered 9484857.
Melissa can hear us.
We can hear you.
We can hear you. Can you hear us? If a lawyer speaks and nobody's around to listen, can he still send a bill to somebody? That's the question.
Let me see. Okay.
Mm.
Can you hear us?
Can you hear us, man? Can you, oh, muted. Oh, here we are. Let's see. Can you hear us?
Well, this is unfortunate.
Yeah, it's unfortunate. Let me see if I can call. Okay, yeah, we could hear you when you were unmuted. I could hear you in your room. Okay, so if you want to unmute, if you unmute your mic, we could hear you. Okay. All right, bye.
So you can hear us?
Yes.
Yes.
All right, I'm not sure what's going on. Sorry about that, everyone. We're still not able to hear you. So I'm not sure if you've addressed any of these questions, Dave?
We did. We addressed it. The one question we had, we addressed that. That was the Summit County one that was John had given us.
Still not getting you. Okay. I guess I'll just read through chat and see if you are able to address these questions. The first one is from Nancy. And if an employer offers health plan, can the employee choose to go to the exchange rather than with the employer health insurance?
In an employer, yeah, an individual can just choose to go to the exchange rather.
Repeat the question just in case people didn't hear it.
Yeah, could you repeat it once more? Wow.
Okay. The question, I think, was if an employer is offering health insurance, can an employee pick and choose whether to go with the employer or go to the exchange? So Dave?
Yes. The employee can decide if the employee wants to go to the exchange. They don't have to take the employer coverage. They can go to the exchange. The problem is they're not going to be entitled to a subsidy in the exchange if they're offered coverage through their employer.
Can you hear on your?
Okay, are you waiting for the next question?
Yes,
Want me to stop sharing? Let me stop sharing my screen here. Maybe
that's a good idea.
Let me do that. I'm ready for the next question. What's going on here?
Go to the messages and see if we can just pick the questions up directly.
Yeah, let's see. I can hear you. I think they can hear, apparently they can hear us. At this point, everyone can.
Okay.
Let's see here.
Hello, this is Melissa. Can you guys hear me?
Yes. Can you hear us?
Hi, I'm helping man it out. So I'm going to read the next question. The next question is from Christina. It says, is there a way to reimburse for the subsidy of Medicare for an employee?
Here's the deal with Medicare. If you are there's a Medicare secondary payor rule out there. And I think it comes into play. It's 16 or 20, maybe it's 16 employees, I can't remember what it is. An employer cannot do anything to incentivize someone to obtain Medicare coverage. So an employer, if they're over, and I can't remember what the limit is, 15 or 16 employees is what I believe it is, you become subject to what they call the Medicare secondary payor rule. If you're larger than that, you cannot reimburse Medicare premiums. You cannot encourage individuals to get onto Medicare, which is a real bad thing for some employers who want to say, I'm willing to pay for the Medicare coverage, but because of your age, you get into my plan, it's going to really increase my premiums because, as I said before, that is a factor that can be used. So you can't do that. If you're a smaller employer, you can. But if you're a larger employer, and by larger, I don't mean a large employer, I think the coverage is around 16 or 20. I don't know. I can't remember what the number is, but there's a number out there. It's pretty low. You cannot do that. You cannot pay Medicare premiums for an employee, and you cannot say that they can't get on your plan.
Perfect. Thank you. The next one, oh, she added on and said, we are a small employer under 10 people. Does that change your answer at all?
Yes, absolutely. If you're under 10 people, you can pay Medicare premiums. Now, I don't know. I make sure that, yeah, those will probably be pre-tax dollars, probably do it with pre-tax dollars, but I'm not sure about the tax implications, but I think you probably can do pre-tax dollars. I'll check that out, but you're not violating any Medicare secondary payor rules. And that's what would be important, is not violating those rules.
Awesome. Thank you. Okay. The next one says, under ICHRA, can the employer get a subsidized plan with a small under 50 employer?
Okay. With an, if you are subject to an ICHRA and it's not affordable, the employee would be able to get be entitled to a subsidy, but they can't, I don't think they can opt into the ICHRA. I don't think you can opt into an ICHRA and take that and the subsidy. You can opt out of the ICHRA and then be able to get the subsidy in exchange, but I don't think you can have the right to say, I'm going to take the subsidy and I'm going to also get the ICHRA.
Wonderful. Thank you. And it looks like just one more. Krista asked and said, would love to hear opinions on a reference-based pricing structure and effectiveness of that model.
Well, yeah, I'm thinking that what they mean by a reference-based pricing schedule is some, I think they try to do it in the level funding world. You hear about this somewhat, where they have a strategy that says, we're only going to pay the hospitals. We aren't going to have contracts with the hospitals. We're just going to start sending them Medicare rates, whatever the Medicare rate is. That's all I'm going to send to them. And they do that sometimes under it's a self-funded plan, but it's called a level funded plan. And that's how we're going to do it. We're just going to send them Medicare rates. And then if they don't like the Medicare rates, they can complain to us and we will fight with them on that and try to give them a rate that we can finally negotiate and agree to. That's a reference pricing I have heard in the past. If that's what they're talking about. The concern with that is you may have some ERISA issues and your employee is hanging out there a little bit when you do something like that, when you're not actually having a contract with the hospitals and the facilities and try to use that type of model, if that's what you're referring to.
Yeah,
Wonderful. And Krista did chime in and say, yes, that's what she was referring to.
It's the second concern that really is, it's almost like playing a game of chicken, where they say the hospitals, which typically raise money in a given community, they have lots of charity events, and they're not going to want to send bills out. And so, but it really is risking things. And it really illustrates the broader point of it addresses the silo involved, but it doesn't address the total cost of care that you have. And when you compare this with things like the first question was on Summit County, if you're really going to look at how do we lower cost so that we're not doubling again from our $3.8 trillion, there are models out there, but the most effective models are ones that anticipate that shifting of cost over, like the Kaiser Permanente model that has been so effective in California. It's effective in metropolitan areas where they align the carrier, the doctor, and even the hospital at times to say, how do we work together? How do we get people in primary care? Community coordination, such as that what existed for many years with Rocky Mountain HMO and then Rocky Mountain Health Plans, or Geisinger in Pennsylvania, rural Pennsylvania, which says, how do we embrace a community approach and find ways to sort of move upstream in the discussion? How do you get people in prenatal care? How do you get people in the primary care physician's office so that you're catching things early? There are also ways to look at it. In the state of Maryland, they have a model where that cost shift that we talked about, going from one silo to another, is ruled out. And it's been this way since the 1970s, where they say there's going to be a state authority that says what a hospital is going to be able to charge for everything, but you got to charge Medicare, Medicaid, commercial, large employer, small employer, all the same thing. So there are different approaches you can take that anticipate that cost shift phenomenon that otherwise we're going to deal with.
The reference pricing, I know you noticed here, just want to know what our overall my thought was on this reference pricing model as an attorney. Maybe it could be effective, but I think you're hanging all your employees out there doing that. I don't know if it breaches a risk of fiduciary duties you have, because you should have contracts. Otherwise, you're sending your employees to a hospital. You don't have a contract with them. Then you think you're going to negotiate something when the individual could end up being responsible for that bill. So I would not recommend it as an attorney.
Thank you. It looks like you did answer Chris's question, so I appreciate that. I can hear you now. I'm really disappointed that we missed part of that. I'm sorry about that technical difficulty. I'm still not really sure
We don't know what happened.
what
So
happened. But
it looks like we were the only ones who didn't hear, which is good. So everybody else got to hear. Gentlemen, we have hit our time here, and it looks like we've answered all the questions that came out. So the portion that we heard was great. It was very informative. We thank you for taking time to share with our community partners, and we will share this video out along with the contact information for ourselves and for David and Steve. And if you should need help in the future, please reach out to us or Hoskins, Farina, and Kampf for advice and technical support. So again, thank you very much. I hope the end of your week goes well. And we've got thank yous coming in on the chat for your time today. So it's much appreciated.
Thanks for having us.
It was a pleasure.
We enjoyed it.
All right.
thank you.
Bye-bye, guys.
Goodbye.